The second speaker is Professor Alfarz Ricardo, Professor of Medical Oncology, MD Anderson Cancer Center. The title of his talk is Update in the Management of Inflammatory Breast Cancer. Please, Dr. Ricardo.
Good, thank you. Thank you so much. For me, it's a pleasure to be here again. This is my fourth time in Egypt, and I want to thank Dr. Hesham El-Ghazali for inviting us. When I said invite us, we are a group from MD Anderson, and this is my first slide that is part of our institution and all of the buildings. So the talk that they told me to speak today is the inflammatory breast cancer. What is the new changes? And this is a little bit what we are going to discuss. I'm going to be in 20 minutes. I have a few slides, but basically some aspects of the epidemiology, some biological aspects, the genetics, and also our group that create a program. This is a clinical and research program. It's called Morgan Welch. And finally, the future direction of this trial. So inflammatory breast cancer is a disease that is very well known for all of you, especially in countries of the Maghreb or North Africans, where the incidence is very high. Basically has been described more than 200 years, and still the characteristic of how we define this disease is more clinical than pathological. So this was Sir Charles Bell was the first author who described as a difference in color, difference of aspect, and also have some symptoms. These symptoms were the shooting pains. So what we don't know today about the inflammatory breast cancer, this is a very rapid progressive disease. Perhaps it's the most aggressive locally advanced breast cancer. Has an erythema that is more than 2/3 of the breast. This are together with the pid orange, and this is a reflexed infiltration of the lymphatic dermal by the cancer, has some induration, tenderness, and of course the DLI of dermal lymphatic invasion that is not a hallmark. And most of the cases we found that the dermal lymphatic invasion, however, is not an exclusive criteria to define the disease. The prognosis, we know that this is a very different prognosis compared with the rest of the locally advanced breast cancer, with the approximately overall survival of 40%. And a very important point, even that the locally advanced breast cancer has between 5 to 10% of metastatic disease de novo, this group of inflammatory breast cancer has a 30% of metastatic disease as a de novo. How this cancer presents, you can see it here. There are many forms. Not always we have the typical rash, and sometimes has not the pain. And of course, sometimes the pathology didn't characterize it very well. So still we use a clinical definition, and this has been our the way that we describe this inflammatory breast cancer. One of the demographic studies in United States stratified by Sears database by multiple cohorts. And you can see here in the from multiple decades, from the early 80s to the late 90s, the inflammatory breast cancer has been the only increase in terms of the incidence, a difference that the locally advanced breast cancer also has been decreasing. So we expect that this tumor has a median age approximately 50 years, and is a unimodal, a different than the rest of the other cancers. The T4 or the locally advanced breast cancer has always a bimodal shape. This is something very interesting to analyze. And also we have a large study. It's called the registry trial, and the data that has not been published yet, but the median that we found in these 350 patients, so the median age was 55, ER positive was 33%, HER2 positive 44%, triple receptor negative 1/3 of this patient, and 50% of the patient has an increase of BMI, and 2/3 has postmenopausal and no familial link. And that was presented by one of the fellows of Dr. Banu Arum a couple of years ago in one of the meetings. So the question was, we know that the breast cancer survival has improved. With this was published by numerous series, and this was Sharon Giordano, one of our colleagues, and this was published in 2004. And we can see here, taking a context of multiple cohorts, we see how the increase or movement up of the shape of these curves. So there is a clear improvement of survival of regular breast cancer, and this can be done by the new drugs, by the incorporation of the screening programs, etc. In the inflammatory breast cancer, there was a retrospective review of this data, and we can see that practically from the 1970s to 1990s, there was no any shift or improvement in survival. However, since 1996, when we start using or incorporating new agents in the backbone of the chemotherapy, this was a poster presented by one of the attendings at MD Anderson, Mariana Chavez, found that there is an improvement in survival of these patients when we incorporate new agents. Is there any particular genetic signature that we can classify this inflammatory breast cancer? And this was one of the fellows of Dr. Bueno and Dr. Lajos Putzeit, Dr. Iwamoto, that he put together these three signatures from Belgium, this Van Leer from BH from France, and Bertucci from Belgium, and they found that basically there was no intersection in the gene signature for any of these signatures. Therefore, we found that there is a lot of room to improve. All of this genetic signature has been published in a small group of patients, no more than 100. And even there are more reported signatures of the IBC. We believe that the IBC might have a completely different signature than the non-IBC group. As other speakers refer about the role of the multidisciplinary role for treatment of breast cancer, IBC is one of the characteristics. And I give a great distinction to work with one of the leaders and one of the pioneers of the founders of these multidisciplinary groups, Dr. Tobashi, who was our chairman in our department. And they started in 1974 working with the pathologists, imagings, surgeons, and the pathologists. So this is a very important how we collect the data, how we discuss the patients together. Like Dr. Cameron mentioned about the team, the importance of having the team of research. This is extraordinarily important in the IBC. So how we treat this patient actually is with our backbone, with taxane and anthracyclines, and we can have multiple ways to administer this chemotherapy in a sequential way, in a combination or concurrent way. The duration of the treatment, we believe that is no less than 6 months, and that's why it's the maximum, the bulking effect. So far, we treat most of our patients in the same way when they cannot participate in clinical trials. There is no specific treatment for triple receptor negative or ER positive. Of course, for patients with a HER2 positive, we add the trastuzumab. And in this group of patients, there is a particular group, very small, that are primary refractory to anthracyclines and taxanes, And we have a protocol, this is called a salvage chemotherapy, that is not a real protocol, it's a pilot study. We treat with the ixabepilone, capecitabine, and bevacizumab. But this is a general frame how we assess the patient. We, most of the time, 70 to 80% of the cases, we enroll these patients in clinical trials. So the multidisciplinary management of the inflammatory breast cancer, we usually administer this chemotherapy for no less than 6 months, followed by a mastectomy and with axillary lymph node dissection, and after that, chest wall irradiation. The pathology results, the amount of residual disease is perhaps the most important prognostic factors for this patient, and anthracyclines and taxanes are the backbone of this chemotherapy. This is another point that reflects this paper that was published by the group of radiotherapists at MD Anderson, and this reflects how important is that the patient accomplish the triple modality treatment, means chemotherapy, surgery, and radiation therapy. So the triple modality treatment is very important. This was 250 patients treated in 3 decades, and you can see in the first slide here in the right, you can see the difference between the patient that had a radiation therapy with chemotherapy, surgery, and the triple modality treatment. Now, the difference between the patient who had the triple modality treatment versus non-triple modality treatment is huge. And so that's why we always, the goal, this was the patient with non-metastatic disease, so our goal is to accomplish a triple modality treatment, because that is, we would like to see this patient in this superior curve. In the particular case for the radiation therapy, and I think there might be some radiotherapists in this group, we can see that there was a difference in patient that has positive margins, patient that has a large residual disease and younger. These are the patients that maybe receive an extra boost of radiation therapy. So now for us it's a standard for the patient that has these characteristics. Instead to provide the 54 grades, we give 66 grades. We have a 3 to 5% of some complications. What are the therapeutic clinical trials that we have for IBC? We have a big group of translational researchers. So we found that many patients has a EGFR overexpression. This is approximately 30% of this IBC. And in a small group of patients, we found that the overexpression of EGFR is associated with a bad prognosis. This was a paper that was published back in 2007. So based on these characteristics, we start doing some laboratory tests, and I'm going to go very fast with this because these are the fused cell lines. This is another problem that we have with inflammatory breast cancer. There is the lack of reproducibility in the lab. Even that these cell lines are from IBC, sometimes are very difficult. But here we can use, in the Western blot, 2 different cell lines, SUM 145 and KPL4. And you can see that erlotinib, that is one of the selective EGFR reversible, increasing doses of erlotinib, there is a dephosphorylation of the PEGFR and also the PAKT. So this was the first step that we found that the anti-EGFR inhibitors can reverse the EMT characteristic of the inflammatory breast cancer. EMT is the epithelial mesenchymal transition. So you can see here that the cells has a epithelial characteristic with the E-cadherin, and when they became very mesenchymal has all of these prolongations, and you can see here, these are most of the expression is the vimentin. With the inhibitors of EGFR, we can reverse this phenotype. So this was the conclusion. It was a paper published in Cancer Research, and we know that basically the conclusion was that the suppression of the IBC tumorigenesis is dependent of ERK, and also we start doing a clinical trial, and we have almost 18 patients at this point, and we use panitumumab, that this is a pan-EGFR inhibitor, is a monoclonal antibody approved for colon cancer, and we combine a 3-month with the nab-paclitaxel and carboplatinum, and the panitumumab we call PAC. We have a multiple biopsies at the same time, and after that the anthracycline-based chemotherapy, and after that surgery. So we have I cannot tell you the results because it has not been published yet, but the results are very promissory, and with this type of trial. These are the current clinical trials that we have open in our group. We have at least a dozen of these clinical trials. We divide the patients if they are HER2 positive, HER2 negative, and for the HER2 negative is our front line is panitumumab, and also we have a very interesting molecule, dovitinib, that is FGF inhibitor with the PDGF and VEGF. And of course, then we have WISHAS close, and we published last year in ASCO this 2007 that was a lapatinib study. We have also another studies with neratinib. We have another study with the lapatinib and IGFR inhibitor or insulin growth factor, and also entinostat, that is HDAC inhibitor plus lapatinib. All of these studies coming from some signaling that we found in the lab, that there is a suppression or combination of signaling pathway inhibitors might have some effect to the cancer. And lately we have a triple receptor negative, that this is our colleague Stacy Mulder. This is a multicentric paclitaxel bevacizumab and a MEDMAB study. And we have a pending couple of studies with the denosumab and Bargatev and also siltuximab, that is one of the anti-interleukin-6 inhibitors. So the current translational research that we have, we focus in the EGFR expression, also the role of the interleukin-6. Seems that there are very few cancers that they are really governed by the interleukin-6. One of the is a rare lymphoma, a Castleman disease, and inflammatory breast cancer also is one of these diseases. Microscopic of a minimal residual disease that is leading by Dr. Jim Rubin and his lab, and of course also some imagings, and we incorporate some new data, how we can reproduce the data from the PET scan in a sequential way. This is our group, the Morgan Welch inflammatory breast cancer. We have this time of the year, the first fellow from Egypt, Dr. Tamer Fouad, and he's from NCI Cairo from Dr. Rabab Menti, and he's with us, and he's going to spend 6 months, and he's rotating in clinical, rotating in the labs, and of course it's going to be, we believe that this is the best way that we can start collaborating with Egypt. So the final slide, this is my conclusions. We need to have a multidisciplinary approach. We need to discuss these patients with all part of the teams. We need to have a clinical trials. This trial to patient, this is a rare disease and very aggressive. It's very similar to happen with many type of leukemias. And we know that this aggressiveness of these tumors needs to have one of these clinical trials to be participated. We need to define still multiple molecular characteristics of the IBC, and we need to know, of course, what is the metastatic process, and see how we can block this metastatic process. This is our Facebook, and we have also Twitter. We have a 10 to 20% of the referrals through the social media, so we pay a lot of attention. And I think I have 20 minutes, and I don't know if you have any question, but thank you for your attention.
Thank you, Professor Ricardo. Because of the sake of time, we'll postpone all the questions to the end of the session.